If you have type 2 diabetes and you're tired of being told it's chronic and something you'll just have to manage forever, if your A1C is controlled but your medication list keeps growing or stays the same, and you know deep down you're capable of more than this, you're in the right place. This is the Diabetes Remission Roadmap podcast. We're Brian Bisher and Corey Jenks, two pharmacists who spent over 2 decades inside healthcare. And we started this show because we got tired of watching capable people stuck getting managed instead of rebuilt. Here's what most people aren't told. Type 2 diabetes isn't just a blood sugar problem, it's a muscle and energy storage problem. When your body loses strength and metabolic flexibility, blood sugar rises, and you can rebuild that. On this show, we break the scripts that say more meds are inevitable, you're destined to just manage, remission isn't possible, and instead we teach you how to build muscle, eat in a way that keeps you full, and regain control of your health again. No extremes, no shame, just practical strategies to help you move toward remission and lead your health again. Let's get to work.
Welcome to another edition of the Diabetes Remission Roadmap podcast. It is Rapid Fire Friday, and Brian is off doing other things. I'm not going to make fun of him because he's in the weeds of life right now, but we have someone even smarter and better looking than Brian, as is always the case.
I don't know about that.
Austin Dudzinski, if that name sounds familiar, it's because you listened to episode 40. Go back and listen to that. But he is just a wealth of knowledge when it comes to metabolic health, diabetes, cholesterol, and I put the call out because people want to know about cholesterol, statins, when it comes to their blood sugar, and I realized I was not up to the task. So for this Rapid Fire Friday, Austin is pinch hitting for Brian. Austin, it's good to see you again.
It's great to see you, Corey. Thanks for having me on. Really honored.
All right. Normally we would have more pleasantries, but this is a Rapid Fire Friday edition, so we're going to hop right into the questions. Austin, I hope you're ready.
Sounds great. Let's roll.
Okay, I'm going to give you a really difficult one to start, in my opinion. So we've heard claims that lowering cholesterol too much or eating a low cholesterol diet, possibly taking cholesterol medications, could increase Alzheimer's or dementia risk. What does the evidence actually show? And when I say we've heard claims, this was a question from one of our Instagram followers. I've cleaned it up a bit, but yeah, low cholesterol, Alzheimer's, the whole mix there, Austin.
Yeah, well, that's a great question. And it's a question that I get a lot as a clinician. I think the big thing that is important to start off with is just to separate two different things. Okay. One of which is a cholesterol level that's achieved via lifestyle modifications versus a cholesterol level that's achieved via drug, because both of those have remarkably different mechanisms about how the ultimate level of the cholesterol is found in the bloodstream. When you look at lifestyle modifications, for example, someone that might be adopting a very low saturated fat, higher polyunsaturated or unsaturated fatty acid diet, they're eating a lot of fiber, maybe just low fat in general and higher glucose, etc. That can, through a variety of different means, result in a lower, for example, LDL cholesterol level, which is the bad cholesterol that everyone worries about as far as causing heart disease. That pool of cholesterol that's found in the periphery, that's found in the bloodstream, really doesn't tend to interact with the brain very much. So when we're seeing a lower level of cholesterol related to a dietary modification, that generally is not, we're not in the scenario where it's like, oh shoot, we have such low LDL cholesterol that it's not getting into the brain and dropping off the cholesterol to some brain cells like neurons or astrocytes or glial cells or anything like that. It's really, those two types of pools don't really interact. The brain, through a specific biochemical pathway called the block pathway, will take precursors like glucose, which ultimately gets metabolized to a little molecule called acetyl-CoA, which ultimately yields cholesterol, and the brain is responsible for basically all the cholesterol production that it needs. So that's the bucket of lifestyle modifications. Where the strong nuance comes into play is related to the medication side of the equation. And there are many different ways to ultimately lower LDL cholesterol via medications. The most common is statins. And so I get a lot of questions about statins. Hey, my friend told me, or my significant other told me, or my family member told me, hey, I'm taking the statin. Am I going to get dementia? Does it increase my risk of dementia? What's going on with that? And then we can kind of touch on the other pharmacological agents too, but statins are the big one that gobble up a lot of the oxygen in the room. So with respect to statins, there's a couple of really important nuances. When we look at population data, so data, big swaths of people, and we look at people that are on statins versus not on statins, and we try to match them super well with these fancy statistical models and stuff, what we find is actually the incidence of dementia goes down with statin therapy. So we see less people getting dementia when they're treated with a statin. The challenge, though, is that an individual is not the population.
Yeah.
So we can make some generalizable inferences based on that data, but every single specific person is different. Everyone metabolizes drugs differently. Everyone absorbs drugs differently. And some people have more of a genetic susceptibility to challenges with drugs than others. So with statins specifically, the challenge with them and dementia is that they do inhibit cholesterol synthesis in the body. So the main mechanism of action of statins is to predominantly inhibit cholesterol synthesis in the liver, which will upregulate the little grabber claw that's on the liver that pulls all the LDL out of the blood. But statins do cross the blood-brain barrier, meaning that they are going to inhibit the production of cholesterol in the brain. So when a patient comes in and they're on a mega dose of a statin and they're experiencing mental fog, this is not something where I'd be like, the population data says that it's not related to the statin, so see you later. It's taking it seriously, doing a full workup, full history. And what I like to do sometimes is measure a sterol panel. So a sterol panel is really cool. It measures 4 different things, basically. It measures lafosterol, desmosterol, campesterol, and cytosterol. So these are all little flash proxies for cholesterol production as well as absorption in the body. So one of the neat things is that desmosterol in particular in the brain tends to correlate remarkably well with desmosterol in the bloodstream based on data that we have. And desmosterol is basically a marker of cholesterol synthesis. So if we have very low levels of desmosterol, then that means that we may be over-suppressing cholesterol synthesis in the brain. So if someone's experiencing mental fog and they get that blood draw and it comes back and they have low desmosterol levels, then that would be an indication for me to say, hey, maybe let's take a step back and see if we can attack your risk of cardiovascular disease related to LDL cholesterol in a different fashion. Maybe we use a medicine like ezetimibe or bempedoic acid, which is Nexletol, or a PCSK9 inhibitor. All of those agents tend to either not cross the blood-brain barrier or they tend to not inhibit cholesterol synthesis in the brain. Ergo, they would probably be maybe a little bit safer. But that kind of dovetails into, I think, a broader point, which is I'm not a huge fan of super high intensity statins. I think they cause a lot of muscle aches, pains, and weakness, some of which can be very subtle. They can cause a lot of fatigue for people. And so I am much more inclined, if a patient needs a statin, to do a baby dose, and then potentially if they need additional LDL cholesterol or ApoB reduction, then I would be inclined to add on something like ezetimibe to that therapy. They work synergistically to get someone's LDL cholesterol or ApoB level to goal. And then dovetailing into the other pharmacological agents, PCSK9 inhibitors, for example, particularly the monoclonal antibodies. So these are like special little molecules that have been made from antibodies, which are little molecules that immune cells produce. What we've done as a human race is kind of manipulate that molecule to a degree where it inhibits a specific protein in the liver that is responsible for breaking down LDL receptors. So more of those little grabber claws stay up and LDL gets lowered through PCSK9 inhibition with those types of agents. Those don't cross the blood-brain barrier.
Quick pause for a second. If you're finding the podcast helpful and you want more practical ideas to help move your blood sugar in the right direction, come follow us on Instagram at Diabetes Remission Partners. We share quick tips, food and exercise insights, and blood sugar mistakes people don't even realize they're making. It's also where we can answer your questions directly in the DMs. So if you want more help between episodes, Instagram at Diabetes Remission Partners is the best place to find us. And when you follow us, make sure to say hi. All right, back to the show.
So we don't find that when you take Repatha or Praluent, which are like the big branded medications, and you drop your LDL cholesterol to 30 milligrams per deciliter or something along those lines, that doesn't mean that you're dropping your brain LDL cholesterol level down dramatically at all. In fact, it probably doesn't even interplay with that cholesterol pool. And we also have genetic data on PCSK9 loss of function, which are basically individuals that mimic that drug for a lifelong exposure. We don't see signals of increased risk of dementia. However, interestingly enough, when we look at genetics that mimic statin utilization, so we have people that have a genetic change in their enzyme that's responsible for cholesterol synthesis, we actually do see a signal of an increased incidence of Alzheimer's disease. So again, based on genetics, based on biological plausibility, it's not as oversimplified as, hey, my blood level of cholesterol is low, therefore I am going to get dementia. It's more, how are we lowering it? What agents are we using? Are we monitoring the appropriate biometrics? And quite frankly, do we need the statin in the first place? Did we get imaging? Are we an appropriate candidate for therapy? Because that's something that is always important to take a step back on.
All right. Person on Instagram who submitted that question, I think you got your money's worth there. So you can see why we brought Austin on and put Brian away for a week. No, I really appreciate the nuance there. And I think that there's camps of people who are like vehemently anti-statin and anti-cholesterol lowering. And there's people who are vehemently pro. And the people who are pro will cite your data that say population-wise, statins reduce dementia. Obviously, everyone should be on a statin. And then there's people who are very anti-statin medications who will say, my aunt took it and became demented. And we took her off it and her brain came back. And everyone's kind of right. And I think that's one of the frustrating things. If you're listening and you've been to a doctor who said you absolutely need this thing and you take it and you feel terrible and they make you feel terrible for feeling terrible when you take it, this is why I really appreciate Austin's perspective of there's so many layers that go into this. Now, if you are taking one of these medications, now we can't give medical advice. We put a disclaimer at the end. But like Austin, you mentioned that sterol panel. Not every doctor is going to know to do that. Not everyone has an Austin in their corner. Would simply taking a brief drug holiday and seeing if cognitive function improves be a reasonable alternative to that sort of lab approach?
Oh, yes. Yeah. Oh, yes. It's nice to have an objective biomarker to look at, but the threshold for discontinuation of statins should be probably pretty low to reassess a myriad of side effects. We know that atherosclerotic cardiovascular disease typically takes decades to develop and culminate in a plaque that ultimately can rupture and cause a heart attack or a stroke. And so taking a 1 to 2 week period of time to allow for the statin to wash out of the body to reassess whether or not you are seeing improvements in cognition or memory or otherwise, muscle aches, pains, and weakness included. I think that is a completely reasonable strategy. And in fact, I would strongly encourage it because there's a lot of ways to attack that type of risk in the body. And we just simply don't need an 80 milligram dose of Lipitor in order to do it with everyone now. These drugs the alternatives generally are generic, or some of them are branded, but have very good commercial or government coverage. And so, yeah, I wouldn't try to pigeonhole yourself into taking a medication that is clearly making you feel like dirt.
Yeah.
And you touched on a really good point, Corey, too, which is there's always a hint of truth in both sides of the equation when you look at this type of thing. You'll listen to a plant-based podcast and they'll be like, yeah, your blood level of cholesterol doesn't even matter with respect to your brain because those pools don't interact. True. But how are you getting that blood level of cholesterol? Are you taking a statin? Because if you're taking a statin, then sure as heck can affect your cholesterol levels in your brain. And those two things might correlate to a degree. Mm-hmm. So those are the important little nuggets of truth that people gloss over, whether you're on the pro-statin side or the anti-statin side. It takes a lot of nuance. And really what it boils down to is the individual's journey and how they feel about everything. At the end of the day, taking a medication that you think is killing you or is making you feel bad or is impairing your quality of life to any appreciable degree, you better make darn sure that you're weighing the risks and benefits of that to ensure that you are getting some good bang for your buck there. Otherwise, what's the purpose of life at that point in time?
You always get that sort of nuance in a 7-minute primary care visit, right? I'm kidding. That's the joke.
Exactly.
Yeah, I'm glad you waited to drink the water before you spit it out with that hilarious observation I made. All right. I think that discussion kind of dovetails. You touched on this in your last answer, but we want the nuance and the truth here. What are the real side effects of statins and which ones get exaggerated?
So lots of questions about that too that come my way. So the main side effects from statins tend to be muscle aches, pains, weakness, and I would say fatigue would be the big ones that I see anecdotally. And depending on the data that you look at, the incidence of that could be 1 in 10, it could be 1 in 5, it could be 1 in 20, it could be really high, really low. There's even some really interesting studies that use a nocebo type of protocol where they'll essentially tell people that they're getting a statin, but they're not, and patients will still report that they have muscle aches, pains, and weakness on a statin. The challenge, though, is that whether they actually are experiencing this related to a statin or not, if they're taking a pill and they feel bad, that feeling is real. It's there.
Yeah.
So whether it's all in their head or not, it doesn't matter. And so if they wake up every morning and take that pill and for whatever reason, their brain essentially turns that into a negative feeling, then that's a problem. And so we need to find something different. So the main side effects, muscle aches, pains, and weakness, some fatigue for some individuals, the ones that tend to be overblown tend to be conditions like rhabdomyolysis, where we tend to get this really severe muscle breakdown. It doesn't happen with every patient that gets put on a statin. The dementia thing is, I would argue, an overblown thing. People are always worried about lowering their cholesterol levels because they're going to tank their sex hormones like testosterone, for example. The data that we have would suggest that statins really don't modulate testosterone to any sort of appreciable degree. We find that if your gonads need some cholesterol to produce a sex hormone, probably going to take it from your HDL particles more than your LDL particles anyways. But the data that we have on statin use and, for example, testosterone would implicate a very minimal change. But at the end of the day, Corey, we can measure these things. So get your testosterone done before you get put on a statin. And then if you're feeling like you're having some issues with challenges with erection quality or duration or libido or whatever, recheck your testosterone level and see where it's at, and go see a qualified healthcare professional that knows how to interpret that knows how to manage that.
Yeah, that's a good point. What we can measure, we should measure. And getting back to the nocebo trials that you bring up, because this is another one of the pro-statin arguments, is these side effects are all in people's heads. You tell them that you're going to have side effects, and then they end up having them. And then their argument is we shouldn't even tell people that they're going to have side effects, which I think is ridiculous, but we're pharmacists, so our job is to educate people about the medicines they take. And that's the reality. Is I have had people on metformin who experience weakness and muscle pain. I say that it shouldn't cause that, but if we stop it and you do experience improvement and you start it again and you experience it, then it's real. Your body is reacting to this no matter what. And I think that's where getting a provider in your corner who is willing to listen is really key. But yeah, I appreciate that we can have the honest dialogue of, yeah, we can have muscle pain, but the rhabdo, overblown. Is there an association with Alzheimer's? Maybe, but probably overblown. Again, the arguments that we want to make for our side, air quote side, especially you get in the trenches on the internet more than me, so you can see what happens there. So
unfortunately,
the world needs people like you to bring some reality checks to both sides of the world. But if you are taking a medicine and you're experiencing a side effect, I would say, one, we're biased. Talk to your pharmacist, because they are the experts in the medications and the side effects. And I think sometimes providers, sometimes to all my doctors and nurse practitioners and PAs listening, these side effects get minimized. My dad is about to start a biologic for an autoimmune condition, and the word that he got from the office was, oh, by week 4, you'll be able to lift a car. You'll feel so good. You can't give people these unrealistic expectations, both pro and negative. So that's why we are on this podcast. You're providing all the information, and I'm trying to provide the comic relief here.
I think you touched on and again, you're touching on these great points, Corey. You mentioned metformin. I think that there's a really important distinction to make between a side effect that may be directly related to the medication or indirectly related to the medication. So for example, with metformin, like you said, metformin is a diabetes drug that lowers blood sugar, can cause some nausea, can cause some diarrhea. So if someone's experiencing a considerable amount of diarrhea from the medication based on maybe a food interaction, maybe they're eating a lot of ultra-processed food rich in fat and carb mixed together, burgers, French fries, pizza, other things like that, that tends to track a little bit more with some more severe reactions related to medications like metformin or the GLP-1 drugs like Zepbound and Wegovy and Mounjaro and Ozempic. And when patients experience a lot of diarrhea, they can get electrolyte disturbances, which can lead to fatigue, which can lead to them feeling crummy. When they stop the medicine, diarrhea goes away. But some of those types of side effects can be intervened on with some counseling. And the same kind of holds true with statins too. Maybe check your vitamin D level. Make sure that your thyroid is optimally working. Consider possibly supplementing with coenzyme Q10. But at the end of the day, I think a lot of providers believe that statins are some sort of magical silver bullet that will absolutely prevent heart disease. And if their patients even question going off of it, they shouldn't even bring up the side effects because of how much of a miracle they are. The answer is that they are helpful, They are a tool in the toolbox, but they are not a silver bullet. Plenty of people can go on and have heart attacks and strokes while they're on statin, even with low LDL cholesterol levels. It's just important not to forget about that, not forget about the human being that you're interacting with too, because they're the ones that live with this stuff on a day-to-day basis.
Yeah, I would argue that they are a silver shotgun shell because we use them like shotguns, like a sniper.
Unfortunately.
However, yeah, that'll be the next Rapid Fire Friday where we just lament how we use medicines willy-nilly. All right, this next question, I'm going to challenge you. You're only allowed to give me a thumbs up or a thumbs down, or you can say yay, or I will interpret for our people who are not watching on YouTube, who are just listening. And if you're just listening, a reminder, we are on YouTube. But this next one for you, thumbs up, thumbs down. Could someone take niacin instead of a statin? Thumbs down. All right.
Probably not.
Okay. You're allowed to expand a bit.
Okay. Statin or niacin appears to do a bunch of really interesting things in the body. So first of all, niacin is a B vitamin. The RDA for niacin is 15 milligrams a day, but when we use it pharmacologically for lipid lowering therapy to modulate blood lipid levels, we're looking at doses 2 orders of magnitude higher. So you're looking at 1,500 milligrams, 2,000 milligrams of niacin a day. So this would be more of a pharmacological dose. And on paper, it appears to do a lot of really good things. We see lowering of triglycerides, which triglycerides tend to be a marker of insulin resistance and metabolic dysfunction. We see a rise in HDL cholesterol. We see small LDL, the hallmark of lipoprotein metabolism associated with insulin resistance, small little LDL particles. We see those go down. We see LP little a go down, which is the new villain on the block, which is a ApoB containing particle that tends to be more problematic for the development of heart disease, at least from the view of conventional lipidology. So again, it's moving all these metrics in the right way. The answer, though, when we look at the outcomes data with respect to whether or not it lowers events, is that it appears it doesn't. It appears it does not lower the incidence of cardiovascular disease. Now, the challenge with niacin is that it's been studied in a very nuanced fashion, because the way that it was studied was to test the hypothesis as to whether or not raising HDL with niacin is going to lower the risk of cardiovascular disease.
HDL being, air quote, good cholesterol.
Yes, the good cholesterol, exactly. And the answer to that is, when niacin raises HDL cholesterol, does that lower the risk of heart disease? I think we can say pretty definitively no. The answer is that it does not lower the incidence of heart disease in that fashion. If we were to rewind the clock and give a bunch of people that were in the original statin trials niacin as a monotherapy, kind of did that in some earlier trials, but it was in combination with other agents, and it's hard to make those inferences, but at the end of the day, just because you're modulating a metric on your lab doesn't mean that you're getting healthier or lowering your risk of heart disease. Cancer lowers LDL, malnutrition lowers LDL, but both of those things are not lowering your incidence of heart disease. The cancer might be, because you're going to die of cancer rather than die of heart disease.
Yeah.
But at the end of the day, it's not a desirable outcome by any means. Niacin also probably modulates insulin resistance in a problematic fashion too, probably increases insulin resistance, and we certainly see signals of increases in blood sugar values and stuff like that. So really there's a lot of other agents that have really strong demonstrable benefits for lowering the risk of cardiovascular disease. Niacin just doesn't have that data, not to mention that it has some signals of harm. So it's just one that whenever I see it on a profile, I always have a detailed conversation with the patient, try to, usually in concordance with their provider, try to taper off or get rid of that medication.
Thanks. Yeah, I think what you brought up is a big idea that we learned in pharmacy school and I think forgot oftentimes are what are called surrogate markers. Because, and if you're listening, you might be told this drug will improve lab marker X by 25%, which is fine. But if you are not living longer and healthier, then that number is merely a number on a paper that looks good. So there's like we call surrogate markers, which show what we think will improve. Like niacin lowers all these bad things. Oh, you should live longer. Oh, wait, you actually don't have any data to prove that. Okay, then there's a deeper discussion of what do we actually want to look at, which I think a lot of our newer diabetes medications are now forced to look at not just blood sugar numbers, but will you live longer with less heart disease? Like I will throw glipizide under the bus till the end of time because it will make your A1C lower and you are less likely to live longer on it. Whoop-de-doo. Thank you for that. The thumbs up, thumbs. I think we might have to add thumbs up, thumbs down as a segment from now on. But the other thing with niacin, I have found sometimes if it's in your multivitamin and you take it and drink a hot beverage and take a hot shower, you might get the niacin flush, which is, if you have forgotten about it from your days in pharmacy school, raising my hand and it happens, it's concerning. Oh my gosh, what allergic reaction am I having?
Oh yeah, some people can. There's a really interesting anecdote, I think, from a podcast with Peter Attia and Tom Dayspring, where he had a patient that called him in the middle of the night because he was having this intense itching inflammation reaction, particularly in the face. And yeah, it certainly can occur with niacin, usually dose dependent, usually formulation dependent too. But yeah, nowadays just don't really deal with that interaction because not a lot of people are on niacin, just not an optimal drug. It would be cool to have more data on it to study it in specific populations. For example, if you studied it in a insulin sensitive population with high Lp(a) that had a history of cardiovascular disease, would modulation of those metrics in that specific context net out in benefit? The answer to that is we don't know. There are some Lp(a) experts that use niacin. Some people are adamantly against it. I think right now the data and my framework would implicate the fact that there's just not sufficient evidence.
All right, thank you. We have a couple more questions, and unfortunately, we are out of time, which just means that if you love this episode, let me know, and we'll have Austin back as long as he'll keep coming and filling my ears with all of this incredible knowledge. So, Austin, thanks for your time. If you want people to find you on the internet or the world, where can they find you?
Yeah, I'm mostly active on X. So my handle is at ApoDuds, APODUDZ. And I actually also recently started a Substack with Dave Feldman. So I'm the primary scientific writer for that, which has been a lot of fun. So you can find me on Substack too at TFP, or just search for my name and that pops up as well too. So.
Holy cow, I did not realize you were on Substack, and now I have to go subscribe as soon as we're off here. So Austin,
Great.
Oh gosh, a wealth of knowledge. And whenever you want to come back, you say the word and you can pretty much fill up all of our time. I really appreciate your perspective. Brian and I are in the trenches helping people day to day with our coaching, with his practice. And so to be able to have someone like yourself who's just clearly a cholesterol nerd, and I say that with all the admiration and love and respect that it deserves, is really a valuable resource for our listeners. So thank you, Austin. And if you're listening and you have had cholesterol questions, I hope some were answered. If you have more, send them to us. We will get Austin back and he will answer more of them. In the meantime, make sure, share this with someone who's told them that they're going to get dementia if you take a statin, and maybe they'll learn something too. But otherwise, you know how we end this thing. Keep it simple and do what works.
If this episode gave you clarity or hope, share it with one friend who's been stuck in the diabetes trap. That's how this mission grows. One person, one family, one story at a time. And if you haven't yet, leaving a quick review helps more people find the show and realize they're not stuck with meds forever. It takes less than a minute and it means the world to us. Thanks for being here, and thanks for being part of this movement toward freedom. Thanks for listening to the Diabetes Remission Roadmap. The ideas discussed here are for general informational purposes only and do not constitute medical or nutritional advice. We are pharmacists, but we're not your personal healthcare providers. Always consult your own physician or qualified clinician before changing medications, exercise routines, or nutrition plans. Results vary, and what works for one person may not work for another.